Hello everyone. So welcome to the online Optom learning series, the fourth session today. Today we have Optom Sumit Kumar. He is a bachelor's degree holder from the Chitkara University in India, Punjab, and he has also earned his master's degree from the Deshbhakt University. Currently, he is a practicing optometrist. His specialization involves vision therapy and he's located in Mumbai, and he's also a visiting faculty at the ITM Institute of Health Science in Mumbai. His basic area includes vision therapy and amblyopia, so that's the reason he's gonna talk about amblyopia and his experiences in the recent approaches in the treatment of amblyopia and more towards the adult amblyopia treatment. Okay, so let's get started. Sumit, you can take it over from here now. Yeah,
Fine.
let's
So,
start.
guys, good morning to all of you. Let's start. So, I'm going to talk about the recent approaches in the treatment of amblyopia. So, now let's say whenever we'll think about the amblyopia, most of the people say it's a lazy eye. But if we'll see, there is nothing lazy in the eye. The eye is not lazy at all. Why that the eye is not lazy? Because whenever a patient of amblyopia will come to us, we check anterior segment, we check posterior segment. So everything looks quite okay in the eye. Still, we call it lazy eye. So the main thing is why we call it lazy eye. So there is when there is nothing lazy in the eye, still we are calling it lazy eye. So there are some interesting facts about the amblyopia. So there is nothing wrong in the eye. If we'll see the retinal receptors of the eye that functions very well, they are normally functionable. So where is the problem? The problem is in the brain. If we'll see, and what is that problem that we are going to discuss in this lecture. So there are some questions whenever we'll think about the amblyopia. Some question arises like, is early patching is a logical treatment for the amblyopia? So depends upon the goal. So main thing is whenever we are thinking about the amblyopia, depend upon what type of treatment you are using for to treat the amblyopia. So if someone will ask to you like early patching is a logical treatment or illogical treatment, or should we start with the patching or no? So it can be yes, or it can be no also. And why that it can be both? So see, whenever if early patching is certainly reduces the probability to develop the amblyopia. So if I do early patching, that can reduce the probability to develop the amblyopia. But the most important thing, if we'll see, early patching also reduces the probability that binocularity will develop. We'll see the see if we want to improve the binocularity of the person, if we want to make his ambient vision or his skills should be better, so that time we have to focus more over on the binocularity rather than the visual acuity that I'm going to discuss later. So depend upon the goal, which type of goal you want, like you want to develop his visual acuity basically, or you want to develop his all over skills. So that is the main thing. The next is whenever now see, if we'll see the we'll always think like what is the proper age of treatment for the amblyopia. So it's a very difficult to treat amblyopia after the age of 8 years old. So most of the ophthalmologists or most of the optometrists, they say it's like it's very difficult to treat amblyopia after the age of 8 years or 10 years. But this statement is false, because there is no scientific study to prove this thing that amblyopia can be only treated till the age of 8 years old. So I just want to explain you what is the proper age. So there is a critical period, and after the critical period, visual acuity, binocularity, and stereopsis cannot be restored, which is a very, very true statement. Now, what is that critical period? So that critical period is just after the birth and just before the death. So it means we can treat amblyopia at any age from the after the birth and just before the death. Now, this is a very, very good study done by Krahe and Medina, in which he shows that if we'll work on neurons, the neuroplasticity work in such a way that we can develop it at any time. We can, if we'll give. Now, there is a study done by Krahe and Medina in which he suggested that, like, if we'll train our neurons, if we'll work on that, then we can develop a vision, or we can train that brain at any age. And there are few more studies done by a very, very good study done by Hewell and Visual, Vicard and Burnham. They suggested that we can treat amblyopia, and if it, even Hewell and Visual has done very, very good study. If we patch one eye for the longer time, it can reduce the neuron connection. It will reduce the neuronal connection to the brain. So now we'll talk about the definition and classification a bit. So see, whenever we are thinking about the treatment or a classification of the amblyopia, it really makes a huge difference in the plan of treatment, that how you define and what you think about the amblyopia. Because whenever you are thinking about the treatment of amblyopia, that time you are thinking about the classification, like what is the changes happening in the amblyopic person, what all the things are there in the eye of the amblyopic person. So it makes a very, very huge difference in the treatment. So if we'll talk about the old definition, if we'll see the old definition, there were lots of changes in that. So there's the old definition was there should be two or more line difference in the visual acuity as compared to the another eye, which cannot be corrected through spectacle or contact lenses. So there should be the two lines difference in the old definition, if we'll see. And and somehow another people were saying, if even if there will be less than 6/18 vision will be there in one eye, which is not correctable through the spectacle or the contact lenses. So these were the few old definition, and this definition was given in 1713, which was the first clinical definition, and the first treatment was given in the 1720, which was occlusion. Till the year of 2014, nothing has changed for the ophthalmologist and optometrist, and the mode of treatment was only occlusion. Until till the year of 2014, everybody was using occlusion treatment. So after that, there is a scientist, very, very famous optometrist, whose name is Seufareda. He suggested a very, very good definition, in which he suggested that amblyopia is a unilateral or infrequently bilateral condition in which the best corrected visual acuity is poorer than the 6/6 in the absence of any obvious structure or pathological anomalies, but with one or more of the condition occurring before the age of 6 years. Now, what he suggested in his study, even the patient's vision will be less than 6/6 pass, then also that person is considered as a amblyopic. Now, another thing, he suggested that if all these things are only possible if this will happen before the age of 6. If we'll talk about like after the 10 years old, we'll see if they, because of any problem, that vision is going to get 6/6 parts or less than 6/6, then we can't consider it as an amblyopia. Now, Seufareda suggested some things like these, all the criteria should be there. Whenever you will think about the amblyopia, this can be the things occurs in before the age of 6 years old, which will give you any type of amblyopia. So first thing is he suggested there can be significant anisometropia. If there will be significant anisometropia means a higher amount of anisometropia, more than 3 diopter, you can see more than 4 diopter. Or second thing is constant strabismus can also cause amblyopia. Then third thing he suggested that if there will be significant and isometropia, like high isometropia will be there, then that can give you amblyopia. Then another thing was significant unilateral or bilateral astigmatism, and then image degradation. So all these things he suggested, like if something like that will be there, then that can give you the amblyopia later on. Now, uh, so one more thing he suggested: whenever there will be visual acuity less than 6 by 6, clinically significant, requiring further investigation. If you feel if all this condition will be there, and if you feel the vision of the patient will be less than 6 by 6, you should think about the further investigation. You have to do all the clinical tests to diagnose the amblyopia. You can't say directly like that this person is suffering from amblyopia, because there are different tests which we have to do to diagnose the amblyopia. Now, one more thing he said, like, what if all the 5 conditions are not there? Suppose if patient is not having all these 5 conditions, like if there won't be any type of constant strabismus, there won't be any type of significant isometropia, then what you can think? Then there can be organic amblyopia. So functional amblyopia may be imposed upon the organic amblyopia. So sometime because of there can be lots of reasons uh, in which your pathological error will be there. So because of that also you can get the amblyopia. So what all the things are there that I'll just discuss it later. But before that, I'll just tell you the behavioral definition. Now, what is the behavioral definition is saying? So, amblyopia is a neurological condition which affects the optimal functioning of the binocularity and many other visual abilities needed for the optimal visual functions. Now, it is a neurological condition which affects the optimal functioning of the binocularity. So, what all the things we we can do by binocular vision, with the binocular vision, like even if I want to play very good, if I want to do any of the activities, we need binocularity. So whenever our binocularity is breaking, there can be something wrong in the eye, or there can be something wrong in the binocular coordination or in the brain. So that I'll just come to this point later, but before that I'll just discuss like what is happening actually in the eye. So behavioral definition is saying it is just the binocular competition between two eyes. So how that binocular competition is happening? So I'm just going to tell you one story. So here, suppose if we'll talk about a teacher and two students. There are two students in a class, and there is one teacher. The teacher is teaching the same subject or same lesson to both the student, in which what is happening, one is understanding very well, another is not understanding very well. And whenever the teacher is going to take the test of both the student, one is performing very well, another is not performing very well, because his learning skill can be little bit bad than the another person, we can say. So what is happening one day, that the one who is doing better all the time, when his teacher is calling him very good, you are doing very good. So most of the time what is happening, like we always call one person, like even if we'll talk about the class representative, like, oh, you are doing very good, you are doing very good. So same thing is happening, that another person will think like, I can't do anything, I'm not able to do anything. So slowly that competition will increase. At end of the day, what it will give, it will give you the suppression. So if we'll talk about the both the eyes. So suppose one eye is getting +5 diopter, another eye is getting +2 diopter. So obviously the visual system of the +5 diopter, we can't compare it with the +2 diopter because there will be little bit of difference in the visual system. So whenever there will be problem in the visual system, the problem will be there in the interaction of the both the eyes. So whenever there will be problem in the interaction, that can give you any type of suppression later on. So obviously slowly, whenever you will start ignoring the +5 diopter, that time it will give you the later on it can give you the suppression. So which will give you any type of amblyopia. So one more thing I just want to tell you about the suppression. Amblyopic eye is not a weak eye. Suppression is an active process. How? Now, if we are talking about the suppression, then suppression is again an active process. I just want to tell you how. So let's talk about this guy. If he can't fight with this another guy, it doesn't mean he is not able to fight ever. And one more example I just want to tell you. Suppose if I'll talk about the Maharashtrian population. So most of the Maharashtrian people, they can speak Marathi very well. But if I'll talk about myself, I'm not from Mumbai, I'm not from Maharashtra, so I can't speak it very well. Why? Because at, whenever there was a developmental age, before the age of 6 years old, I have not learned Marathi at all. So but if we talk about any of the Maharashtrian guys, they speak very well Marathi because from the childhood they have learned that language. So the same thing is happening that it. But if I talk about the second thing, it doesn't mean that I can't learn that Marathi. I can learn it and I can speak it very well at any age. So that is what the suppression is, means we the cells are active and we can develop it at any age. We can train the brain to develop it, to improve to visual acuity, to work it at any age. Now these are the few classification of the amblyopia: anisometropic amblyopia, isometropic amblyopia, strabismic amblyopia, and deprivative amblyopia. These are the functional amblyopia we call it. And I don't want to explain it more because this is not I don't think so. This is not in my topic. So I'll just directly go to the little bit about the evaluation and then about the treatment parts. I hope you all are aware about this classification. So one more thing is there. If I'll talk about the organic amblyopia, the main cause is ocular pathology. So, so if I'll talk about the true organic amblyopia, is very less common. See, if I'll talk about the only because of toxoplasmosis or vitamin B, or only because of some drugs like alcohol, quinine. So this is not pure, but sometimes because of functional amblyopia, because of toxoplasmosis or corneal dystrophy, it can give you the functional amblyopia. So you have to differentiate, like how to differentiate the organic amblyopia and functional amblyopia. Now there is a some etiology of the amblyopia, like why the amblyopia is happening. So first of all, what is happening, like there will be blur image and there will be difference in the image size. So let's see an example of +8 diopter and +3 diopter. So if I talk about +8 diopter, obviously he will see more blur image as compared to the +3 diopter. So there will be difference in the image. Obviously, there will be lots of anisoconia, and one of the major and important part, if I'll say, there will be abnormal binocular interaction in both the eyes. There won't be any type of eye coordination, we can say. But retinal receptor process in the amblyopic eye are essentially normal. If we'll see all the retinal receptor, they work properly in the amblyopic eye. Effects on the developing visual nervous system are cortical, not ocular. So there is one more thing which is known as MNT pathway. We call it sometimes focal and ambient vision also. We call it dorsal and ventral pathway. So if we'll talk about that, then most of the time our ambient vision is getting affected in the amblyopia as compared to the focal vision. Because ambient vision is the only vision which work on all the visual skills as compared to the focal vision. So focal vision, we call it what and where pathway also. So your what pathway is only working, your where pathway is not working in that. And if you see the ERG, that is also normal in the amblyopic eye. Next is amblyopia deficient visual ability. Suppose if a person is getting amblyopia, what all the things can be there? What all the diagnosis you can do? Like clinical, what all the things you can see? So first thing is deficient eye movement fixation skills. So you can see poor saccadic movement, poor pursuit movement. You can see, or you will see the fixation of the phobia. That will be unsteady, and sometimes it can be unsteady or eccentric fixation. Depend upon the which type of amblyopia is there. Like if a person is suffering from the isometropic amblyopia, there can be steady fixation, and there cannot be eccentric fixation. So depend upon the sensory adaptation, which type of sensory adaptation. If we'll see the strabismic amblyopia, there can be a particular eccentric fixation. So because of that eccentric fixation, there can be amblyopia. So increase saccadic latency and reaction time for the eye-hand coordination. So obviously, if there will be poor saccadic movement, that can give you any type of poor eye-hand coordination. Decrease pursuits accuracy, as I already explained. Then there can be deficient accommodative skills. There can be decrease in the amplitude of accommodation, accuracy, and sustained of the accommodation. Then next is increase accommodative latency. So what does it mean? So whenever if there will be in any person with the amblyopia, there can be different problem in the visual skills, like you in the tracking, in the focusing of the object, in the to focus for the longer time, in the eye coordination. We can say that there will be different type of visual ability problems. Now next is your there are few more visual abilities which are like poor form discrimination due to decreased contrast sensitivity, spatial uncertainty, reduced visual information processing. There are 7 skills, the visual information processing, like visual discrimination, visual sequential skills, visual like this visual spatial skills. This type of skills are there, so that can be poor in the amblyopia. Now we'll talk about the optometric evaluation, which is very important part. So first is you have to check visual acuity, near as well as distance visual acuity. Next is you have to do refraction. You have to check the visual acuity with the pinhole, and you have to check the keratometry or topography reading. And then you have to do the Bruckner test, which you have to do with the ophthalmoscope, and then ocular motor test, in which you have to check the saccadic movement as well as pursuit movement. Then another is your crowding phenomena. So crowding phenomena is just like a person, if will give a if will give a single word to read, a person he can read, but if will give a full line to read the same person, he won't be able to read with the amblyopic eye. So that is also a very important part in the amblyopic diagnosis. Then you have to check fixation status of macula centric or eccentric, whether it's a centric fixation or it's an eccentric fixation. With that, you have to check this whether it is steady or unsteady. One more thing is you have to check 4 prism base out or 6 prism base out prism test. Then one more thing is a Worthwood dot test, which is very important test. You have to check, which will with this test will come to know whether which eye is getting suppressed. Then stereops is also, it is most important tool to diagnose the suppression or amblyopia. Then there are some eye health which we have to check, like whether the anterior and posterior segment of the eye is proper or not. Then you need to check the visual fields or a muscular grade chart. Why these all these things are very important, because sometimes patient can suffer because of any type of pathological error. So to distinguish both the things, to give the differential diagnosis, you have to check all these things. Now let's talk about the management part. So to understand and treat amblyopia in the most effective way, you must understand the neurology of the amblyopia. So whenever you are thinking about the amblyopia treatment, you should understand what is happening in the eye, what is happening in the neurology of the eye. So I'll just again give you one more example. Suppose let's take an example of a class. In the class, there are two kids. One is very talkative and another is not so much talkative. So it doesn't mean that the person, the boy who's not talking at all, he's not very talkative, it doesn't mean he can't talk at all. We can just give a training to that boy and we can just explain a little bit more, we can just change his behavior and make him to do all these things just like another boy. So that is same thing we are doing the amblyopia also. Suppose there are there are few neurons which are not working and there are another neurons which are working. That is why you are, and how you will come to know about that, you can just see your focal and ambient vision if will and what and where pathway is also there. So just close your good eye and just ask about the person, ask from the person like whether you can see something or whether you can't see anything. So he will definitely tell you, yeah, I can see there is something. Like he won't be able to tell you directly, but he will say, yeah, I can see something. So that means your eyes is working. It doesn't mean like your eyes is not working properly. There is nothing wrong in the eye. So first of all, you need to understand the neurology. So definitely the neurons which are not working, you can just train that neurons and definitely you will get a result. Now if I'll talk about the amblyopia, then there is a very good example of the iceberg. The tip of the iceberg, you can see it is very small, and the area below the water, you can see there is a huge area below the water. So most of the time, whenever we'll think about the amblyopia, then we always think visual acuity is the most important part in the amblyopia. But here we can see the tip of the iceberg is just the visual acuity, and rest all the parts, if we'll see below the water, that is the your all visual skills, like your accommodation, your saccades and pursuit movement, your visual information processing, your visual motor, your ocular motor, your fine motor skills, your gross motor skills. But we always think about the visual acuity. So you have to change your perspective to that. Like whenever you are thinking about the amblyopia, you have obviously you have to think about the visual acuity, but most of the time you have to think about all the skills which you can see below the water. So most of the time you have to work on the visual skills as compared to the visual acuity. Now there are the different treatments for the amblyopia. Since a long time we are using occlusion, we are using different type of patching therapy, or we are using high lens, full lens prescription. So I'm going to discuss with you one by one. So if you see the ophthalmological literature, they always use total occlusion, full prescription, or with the or they are using some cycloplegic drops or Bangerter filter. But yeah, if you see the optometric view, optometric study, so people are using some lenses, or sometimes there won't be any use of no any type of patching, or no occlusion will be there, or only the partial occlusion they are using. and then they are using vision therapy. Now, what are the disadvantages of the full patching? So I just want to discuss with you. Full-time patching reduce the performance in the life and ability to learn. So if I'll do full patching, that will obviously, as I already explained to you, that is going to decrease learning skills. So whenever, if you later on think about to develop the binocularity, it won't be possible to develop the binocularity. Full-time patching eliminates the possibility of developing binocularity. Full-time patching reduces the child field of vision. So whenever, if I talk about the field of vision, that is also going to decrease in the patching. Then it can sometimes it will give you double vision also. So obviously, if you patch the one eye for the longer time, and when your amblyopic eye will start developing, you can get the double vision. Now, see, if we'll see the results of the total occlusion, you can see the most of the kids, they will get anger and anxiety, all the behavioral issue you can see in the um, when you will do total occlusion. Now, if you see the another thing is there is a full power lens prescription. So based on the maximum plus and dilated refraction, sometimes most of the optometrists or most of the ophthalmologists, they are prescribing maximum plus. If some person is getting +5 diopter, then they always try to give the full lens prescription. Second thing is whatever they are getting in the dilated refraction, they always try to prescribe that. So their main goal is provide to visual acuity. So they always try to give the full prescription, then they always try to provide the visual acuity. But what seems to be optimum is not what is the best. But see, it doesn't mean like if they are prescribing +8 diopter or +5 diopter, then they are going to achieve the goal. So depend upon the goal, what is their goal. So obviously, if they are thinking about the visual acuity, then they are correct on their point. So if you see the classical treatment, there is a very, very weak link in the classical treatment. Is full-time patching and full optimal prescription ignores neuroscience research and treats amblyopia as a monocular problem instead of binocular problem. So if we are focusing on the patching, that means we are not thinking about any of the neuroplasticity, or we are not thinking about any of the neuroscience. So why there is a poor connection, or we can say poor link in between both the things? Because whenever we are doing any type of patching, we are not thinking about the binocularity. It is not going to develop the binocularity level at all in the later stage also. So most of the time we should think about the binocularity if we are treating an amblyopia. That I'll just discuss it one by one later. Now, so there are some keys to success in the treatment of amblyopia. So first is your behavioral lens prescription, behavioral use of occlusion, behavioral and neurooptic metric vision therapy. So what is vision therapy is doing in the brain? So it is changing the neural connection in the brain. So it is working on your neurons in such a way like your brain will start understanding the connection. It is going to make a connection between the eyes and brain. Now, what is the key concept? So neuroplasticity and neurogens exist throughout the life. So it is not like that your neurons are not working, they are just sleeping, and you have to just make them awake. And neuroplasticity is the process by which neurons can increase their connection with other neurons through sensory stimulation, learning experience. Obviously, you can develop that neurons, you can improve, you can just train that neuron with the training, with a particular learning processor, and you can just make the amblyopic eye working well. So how to prescribe lens on the basis of neuroscience? So let's say whenever you are going to prescribe lenses in the case of amblyopia, you have to keep all these things in your mind. It can be based on the distance retinoscopy, subjective refraction, and the near point retinoscopy. So we have to check whether that person is going to have any type of lead of accommodation or lag of accommodation. What is his distance retinoscopy? What is his subjective reflection? So most of the time, whenever you are thinking, you have to think about all the visual skill, not directly on the only on the visual acuity. And second thing is you have to perform tests monocularly as well as binocular field situation. So the person binocular situation should be there, like both eyes should work together, both eyes should open and just perform all the tests. So that will be the one of the best method to prescribe the lenses. Refractive compensation based upon the minimal compensation to achieve maximum binocular result. So again, the main thing is you have to think about the binocularity. One more thing, you can just think about the Worthwood dot test. You can just do the Worthwood dot test at the different distances, near, intermediate, and distance also. Suppose I'll just give you an example like how you can prescribe glasses on the basis of Worthwood dot test. So I'll just explain. Just take an example of plus 6 diopter of hyperopia. Suppose if one person is having plus 6 in the one eye and another eye is having plus 2 diopter. So there is a little bit of anisometropy we can say. So one thing is, first of all, you just perform Worthwood dot test at 1 meter distance, and slowly, just check it at the different distances. So suppose if you instead of plus 6 diopter, if you are prescribing plus 5 diopter, and that person is getting fusion, developing his fusion at the distance of 3 meter, and with plus 6 diopter, his fusion was till the distance of 1 meter, then you should go for plus 5 diopter as compared to the plus 6 diopter. Why? Because we are thinking about the binocularity. We are going to prescribe the lenses on the basis of binocularity, not the basis of visual acuity. Obviously, visual acuity is also a very important thing, but it's not like that you are decreasing your visual acuity from 18 to 624. It should not be like that. Yeah, half of the line difference will make a little bit change, but yeah, you don't have to decrease moreover the 2 lines or 3 lines. Then whenever if you are going to prescribe any type of lenses, then just try to prescribe contact lens to that person. And why we are going to prescribe the contact lens to that person? So whenever if there will be significant anisometropia, there will be different size of the image, there will be anisoconia also. And whenever if there will be anisoconia, there will be lot of competition in both the eyes. So first and most 4 things you have to keep in your mind, that you have to prescribe contact lens. Why? Contact lens will work on your anisoconia. It reduce the like binocular retinal rivalry, we can say, which is the competition between the both eyes. It decrease the retinal rivalry, and which will give you the binocularity, which will try to make the binocularity in the both eye, whichever may name. So whenever we'll prescribe uh, contact lenses, so what is our main goal behind this is reduce binocular competition and improve binocularity. Now, next is your active vision therapy. So the purpose of amblyopia therapy is to maximize the patient's performance in visual related tasks such as academics, sports, and driving. So if we are trying to give the vision therapy,
Sumit,
we are not.
Anish here. I wanted to add
Yeah,
something.
I'll just explain it to you later. You can add it later. Can you just wait
Okay.
for some time? Yeah, yeah. So the purpose of the amblyopia therapy is maximize the patient's performance in visual related tasks such as academics, sports, and driving. So we are not only focusing on the vision, we are going to focus on the different tasks, like his sports performance should be better, his academics should be better, and whatever his daily needs, whatever work he's doing, his driving skills, his all the skills should be perfect. So successful treatment can be accomplished and a long-term cure sustained if the emphasis is on developing high degree of binocular function. So obviously, if you'll work for the longer time, suppose if you'll teach, if you'll give a particular training to that person, he's going to understand, and he suppose I'll just give a random example for that. Like suppose if you once you will teach a particular lesson to a person, he's not going to forget that thing. So same way, will vision therapy is also going to work in the same way. Whenever we'll teach a particular things to a person, he's not going to forget that. So we are, because learning is a vision is a learning process. So vision therapy is also going to work like that. Then, if we'll see the approach of syntonic optometry, a great scientist, Dr. Harry Spittler, he believes that if we'll administrate a particular amount of light, or if a particular color in the eyes, that is going to work on the autonomic nervous system. It makes the balance of the parasympathetic and sympathetic nervous system. So that is how it works. And if we think about the amblyopia, then we have to administrate red or amber color. That is, there are some studies which suggested that we should use this. Then, if we think about the vision therapy, what all the things we should do? So first thing is, you should work on the gross motor therapy. You should give the gross motor therapy, which is going to work on the gross motor skills. Like how it is going to work is, it is going to develop your visual spatial localization. And obviously it is going to work on the coordination of the right and left brain coordination. Then there is something called oculomotor therapy, and how you can give that oculomotor therapy is through the heart chart. You can give, there is a software called as Amblyopia iNet. So you can use that software also to develop the oculomotor skills. Then there are some tracking books which you can use to develop the oculomotor skills, like saccades and pursuits. Then there are some saccadic strips, so that also you can use. And there are some softwares like Vision Therapy System 4 or Sonnet Vision Integrator, which are the mostly used in the treatment of the oculomotor therapy. So through all these things, you can give oculomotor therapy. Now, second is accommodative therapy. So whenever you are going to give the accommodative therapy, so you have to you have to give the minus lens therapy, which is going to work on the amplitude and facility, both the things you have to improve. Then there is something called near far rock. So that is also you can give. Then spatial discrimination lens sorting. So there is something called lens sorting therapy. So that should be give to develop the accommodation of the person. Then lens flipper facility and power you should give. Then distance minus lens technique. So you have to give the minus to develop the amplitude of the accommodation. So these are the accommodative therapy you should give initially to the patient. Then you have to work on the central fixation. So you can just take a flashlight, normal camera flash, and then just put a horizontal in one eye and vertical, the way you check the eccentric fixation in the eye. So in way you can start the treatment also. So a vertical flashlight in the one eye and horizontal in the another eye, and you have to ask the patient which type of image you can see. So most probably, if there will be binocularity will be there, or eccentric fixation, depend upon that. So I have explained down like which type of image he will see. So you can see the pictures also. So there is another thing is you have to work on the eye coordination. So you can just give you can just tell the patient to do the coloring. You can just tell patient to cutting the paper or drawing, tracing. So all these things you can give to develop the eye hand coordination. So there is one more thing: stringing, beads, and the pegboard, which is the mostly used to develop the eye hand coordination. Then software is also there, which mostly work for the eye hand coordination, Sanet Vision Integrator. Then form perception and perceptual discrimination. So whenever you are going to work on the form perception, means you have to find something in the, like you have to work on the crowding phenomena. So mostly whenever if there will be amblyopia, they definitely they are going to have crowding phenomena. So you have to work on the form tracing through the amblyopia inet, or in the VTS4 also we have a system like this. So you have to work on the visual memory and all. Then monocular precision. So whatever I told you till now, that all these things you have to perform monocularly as well as binocularly, because we are not only going to treat the monocular eye. It doesn't mean we are going to work only on the one eye. We have to work on the non-amblyopic eye also. Now there is one more thing which is known as monocular training in binocular field. So what is that training is, you can give through the VTS4. There's a bar reader, as you can see over here in the picture also. This is known as bar reader. So whenever your one eye is working, another eye is blocking, and this is going to work on your central and peripheral fixation. So if whenever your peripheral fixation is going to block and your central fixation is only going to work in the bar reader. Another thing is you can work through the TV trainer also. That is also, TV trainer is mostly used for the anti-suppression therapy. And then you can use Sanet Vision Integrator to develop the peripheral fusion, and like this, there are different activities. So now we have developed single eye. Now we are going to work on the binocularity. Like we have to develop the binocular coordination of the both eye. So first thing is you have to use VTS to develop the vergence at the different level. You have to improve the convergence level. You have to improve the divergence level of that person, and definitely you have to work on the stereopsis, which is the most important thing in the amblyopic eye. Then sensory and motor fusion you have to develop. You have to work on that. Then try to eliminate the suppression. So it doesn't mean the person is going to have, suppose if it's person with the strabismic amblyopia, you can develop the central fusion, but there can be difficulty in this peripheral suppression also. There can be suppression in the different gauges. So definitely you have to work on the different gauges. Then you can give the binocularity exercise with the block string. You can use vectogram to develop both the anti-suppression therapy, and you can work on the stereopsis also with the vectogram. Then there is one more thing, anaglyph exercises, which like you can see the slide over here, the kid is trying to do something in the board. So you can see there are double images when you will wear red green glasses. So you have to try to make it single. So that is what is anaglyph. Then something is called as Sanet Vision Integrator. Again, that is a very important tool in the amblyopia exercise, which will work on the eye-hand coordination. You can use it for the motor skills also, gross motor, fine motor also, and oculomotor skills also you can develop with the Sanet Vision Integrator. Then there is something called Lifesaver Card, which again we use for the peripheral awareness, or you can say convergence and divergence. Both the things can be improved. Then aperture ruler, again it is used for the divergence and convergence. Then mirror stereoscope, again it is for the training we can use. So these all the skills. So whenever first of all you have to work monocularly, and then later on you have to work binocularly on all the skills, because we have to work on the binocularity. So what is the conclusion of this thing is, don't forget to treat the whole child or adult. You're not treating an amblyopia, you are treating a person with the amblyopia. So why we say this statement? Cause see, because of the amblyopia, it is not only his vision is going to hamper his all the skills. He won't be able to drive properly. See, he won't be able to play properly. He won't be able to perform his different visual skills, different skills like his daily even. So we are not treating the person with the amblyopia. We are going to work on the whole body. So we have to work on the all the skills. So third thing is you also need to work on any problem in learning motor, bilateral integration, perception, etc. So it is not only you have to work only on the visual acuity, you have to work on the learning skills, you have to work on the bilateral integration with the coordination of the left and right brain. You have to work on the motor skills, you have to work on the sensory skills, you have to work on the accommodation, you have to work on the seconds or pursuits, eye movement. So there are lots of skills which we have to improve in the amblyopic eye. It's not only the visual acuity. So these are the acknowledgements. So I have used some books like Applied Concepts in the Vision Therapy, which is by Dr. Jeffrey Cooper, then Von Wooden. You must be aware about this book more. Then Seeing Through New Eyes, then Visual Diagnosis and Care of Patients with Special Needs by Dr. Mark Taub, then Basics of Binocular Vision by Michael Sheeman. Then I'm very thankful to Dr. Robert Sarnet. He has given this knowledge to us, and we are enjoying it. And my another teacher is Mr. Montoyakon. So I've learned all the skills from him. So I'm very thankful to both of them and all this um, guys. So if anybody have any query, they can just ask. Yes, Anis, I can. I think you want to explain something. So, hello, so
Sumit,
Fakhruddin sir. Yes, sir. Yes,
Hello.
sir. Tell
Yeah.
me.
Yeah.
Can you just unmute the Anish if it's possible? He wants to say something, I think.
Yeah. Go ahead, Anis.
Yeah. Yes.
yeah, Hashim. I
Yeah.
was
Yeah.
about to
Anish.
clarify a little thing about the
Mm,
anisoconia.
yeah.
And in case of anisommetric amblyopia, the thing why it is causing amblyopia, right? When there is a plus lenses or
Yeah.
whatever the
Yeah. Yeah.
daptic
Correct.
power difference in the both eye, why it is leading to amblyopia, right? So I want to brief about this.
Yeah.
So
So,
basically,
should I explain, or you want to explain, or what? Like,
I'll explain a little bit.
okay, sure.
So sorry.
Yeah. Yeah. Anish, go ahead.
So whenever we have the daptic power of 1 or 2 diopter difference in the both eye, that usually create a anisoconia up to 2%.
Yeah.
One diopter is equal to 2% image size difference. And
Correct.
what our brain can tolerate up to 5% image size difference clinically.
Yeah.
Yeah. So what basically we are doing while prescribing contact lenses or glasses in the anisommetric amblyopia is we are trying to reduce the anisoconia. How it's work
Yeah.
is if you take a +5 diopter lens in front of your eye and if you pull it close to your eye, you'll see the background image will be minified. So while you
Yeah.
are transferring the glasses to contact lenses, it is actually decreasing the image size, and which is unfortunately going to decrease the anisoconia and increase the binocularity.
Yeah, that is correct. So, Anish, I think this is all you want to say, or you want to say more?
And regarding neuroplasticity and neurogenesis,
Yeah.
neuroplasticity is something that in your class there is a 30 students and 30 of them are not talking together. So
Correct.
what we neuroplasticity does is we are making the 30 students to talk with each other. And in case of neurogenesis, there is a growth of new neurons.
Correct.
So while treating the amblyopia, we're actually increasing the neuroplasticity. So each of the cells are talking together, and unfortunately, it is increasing the binocularity as well as visual acuity. Thank you.
Yeah. Correct.
Okay. Thank you very much, Anis, for your information. So let's,
Suggestion, like whatever. Yeah,
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 thank you, Sumit,
yeah. So I'll
also
just read
for a
the.
brief.
Uh,
Yeah, I'll just ask you because I have
yes.
jotted down the question, so you can just give your
Okay.
answers or your ideas. So there are a couple of questions which have been asked. The first question was,
Okay.
what do you mean by image degradation? So
So
there was
image
somewhere this.
degradation is, yeah. So whenever there will be, if there will be some cataract, congenital cataract, or any corneal opacity, then there won't be any type of development in the, like, they have never seen the any type of light, so that is going to give the image degradation. Image degradation means they have never seen any type of image, only the, we can say, light perception. So that is what it means.
Or
I
probably the
think.
quality of image is
Yeah.
not same between both the eyes. So I
Yeah.
think that would be one of the important thing that we need to understand, that the image is maybe still present, but the quality of the image is not that good. So that means
Yeah.
by image degradation is like taking a picture with using a 32 megapixel camera and taking a picture with using a 5 megapixel camera. So the image is not that good.
Correct.
There is a quality decrease or reduction in the quality. So I think that's what image degradation would mean here. Can we diagnose amblyopia by using a scan? There was one question regarding that.
I don't think so. Like, we have never used, and I have never listened about this thing. Like, there is no use. I
Yeah,
don't know.
I also don't think you can diagnose, but definitely it would be a useful tool to
Hello.
measure the axial length if you have some anisometropia or large myopic prescription. So I think it's more towards getting to the axial length measurement. But as for diagnosis is
Yeah.
concerned, I don't think it's a diagnostic tool. That's what my experience in
Correct.
amblyopia goes.
Hello. Yes. Yes.
Uh, yeah, the other question
So
is how to explain amblyopia to patients, because as we discussed or as we understood just now that it's a neuron problem. So do you have any
yeah.
tips or guidelines you usually follow to explain to the parents or explain to the patient about amblyopia and how you're going to manage them? Is there any way you,
Okay.
is
Okay. Yeah. Yeah. Whenever you are going to explain about the vision therapy or about the amblyopia, so main thing is it just depend upon your counseling, like how you are going to counsel the patient. So usually what I explain to patient, like, suppose if you want to use your left hand for the longer time, for few years, then what is going to happen? So obviously it is not going to work for the after that. So same thing
Mhm.
is happening with our eyes also. Suppose if you are not using your left eye or right eye for longer time, so definitely it is going to leave the work. It is not going to work later. So we have to make it
Mhm.
work by such training. We are going to give a particular training to that, and that training is known as vision therapy. So this way I am explaining to my patient. You can give lots of example, like, there are lots of example depend upon person to person.
Person to person, yeah, right. So
Yeah.
I think the easiest one is, why are you right-handed? Why don't you use your left hand? You know, so we can actually ask it accordingly and explain to the patient that you are right-handed because your right hand is much more used. So we want
Yeah.
both hands to
Yeah.
work
So
and all that. So that could be one of the simplest way on how you can explain. So the next question is, are there any vision therapy systems other than VTS and SVI which you know of for amblyopia treatment?
yeah, there are many more, like amblyopia inet, except amblyopia inet, and there is amblyopia inet, which is basically for the amblyopia. So through that software, you can treat amblyopia. Then there is one more software newly come, like Binox. So that is the one of the best tool for the amblyopia. I think it really works for the amblyopia. So that also you can use. Suppose if nobody has any software, so we have. Our optometrist is very famous, like Oli Abdullah. So he you can just directly contact to him, and he will definitely provide you.
Yeah,
So
nowadays
even
this
if you
software.
one more thing I just want to tell you, like, even if you don't have anything, even if you don't have any of the software, it doesn't mean you are not going to treat that patient. You can just start with a few things. Obviously, if you want to get 100% result, you need all this equipment, and you need all the proper equipments, like all the original equipment from the Bernal kit. But yeah, most of the time it is not possible for all of us to get all these equipments, because
Mm.
as we can see, like optometry practice is very low. And the second thing is we can't afford it, but still you can start with a hard chart, and you see, if you know the concept, you can improve it anyhow. It doesn't mean like
Yeah.
you're going to leave that patient. So that is what I think.
True. So the basic thing is there is no need to have. It's definitely an advantage to have good equipments, but you can start slowly. Simple playing games to kids using one eye and
Hmm.
stimulating them, and then using both the eyes together is also applicable. And if I'm not mistaken, there are certain softwares also available where you can, give those softwares to the patient to play games at home. And
Yeah,
sitting in
that's
the
what.
office, you can measure their, improvements. So
Yes,
that's also something new. I think VTS5 or the one Binox has that facility where the patients can actually buy the software, and it's
yeah,
actually the games which the patients play at home, and then
correct.
you can as an examiner monitor it at your office or at your end. So that's I think is a good advancement in terms of amblyopia treatment.
Yes.
Can you please explain in brief about Bruckner's test? So
Yeah, so
in
in the
how
Bruckner
it
test,
is
we have to put the we have to first of all just dilate the patient and just put the ophthalmoscope light in the patient's eye, and the eye
Mhm.
which is having a high glow, that like brighter glow, we have to check brighter and dull glow. I'll just use this term. So the eye which is having brighter glow, that is amblyopic eye, and then the eye which is having dull glow is that is the non-amblyopic eye. So that is the one of the best tool to differentiate like whether.
Yeah, I think it's well written in the textbooks also. What's Bruckner's test
Yeah,
and
yeah.
how do
So
you do
yeah.
it? So yeah, that was a good clarification. Is there anything different you do? I mean, do you still follow the textbook? How do we normally do, or is there any specific differences on how you perform Bruckner's test?
Sorry, come again, sir.
Is there any different way you use to perform Bruckner's test, or is the normal way at 1 meter you just
No,
shine the
not
light and
normal
see
way.
the
Normal way, sir.
normal way?
This is the only way I have learned,
Is the
and
only way.
in the Von Noden, or if you'll see another this Michael Schumann book, that there also they are
Yes.
mentioned the same thing only.
Yeah, yeah, true. Is there any specific lens design or bifocal that needs to be used? Have you been using bifocal lenses for patients to
Yeah,
treat
yeah, we have
amblyopia?
to. Yeah, we have to give plus lenses. Why? Because depends upon the accommodation. As I explained to you, like whenever we are going to prescribe lenses on the basis of behavior lens prescription, then one thing you have to keep in your mind, that your accommodation should be proper. Like there should be the normal value of the MEM retinoscope is plus 0.5 to plus 0.75. So
Yeah.
that should be normal. Suppose if a patient is going to the lead of the accommodation, at that time you have to prescribe to relax the accommodation. You have to use plus lenses for the near. So
Yeah.
there sometimes we have to keep bifocals very high, and second thing is you have to prescribe plus lenses for the near. So that is very good thing.
Okay, so you have an experience of prescribing bifocals to amblyopia
Yes,
and it has worked.
yeah.
Yeah, okay.
I have just prescribed. I have prescribed to many people, like,
Okay, okay.
and I have a
And
good result.
good results, yeah, yeah. Are contact lenses always good option for anisometropic patients? Do you have some thought on
Yes,
that?
yes. So that I explained already. Like first of all, if
Yes.
there will be any type of uh, amblyopia, or if there will be any somatopia, definitely we have to go for the contact lenses, because there will be anisoconia, and that anisoconia is going to give the retinal rivalry, which is the competition between the both the eyes. So to
Yeah.
reduce that retinal rivalry, we have to give the contact lenses, which is very good, and which is going to decrease the anisoconia.
True. So yeah, a contact lenses definitely helps to reduce the anisoconia, thereby helping in terms of binocularity development. So it should be definitely a very good option for treatment in terms of amblyopia management. Even if it's metropic also, it's a good option. Okay, we'll take two more questions, and then I think the rest questions we'll answer it later when it comes to uploading your pre-recorded video, because we are short of time. So let's take two more questions. Yeah. In terms, if the amblyopic patient has developed suppression, will the patient struggle with diplopia if you prescribe vision therapy?
Sorry, just come again, sir. I didn't get the question.
The question is, if the amblyopic patient has developed suppression, will the patient struggle with diplopia if you prescribe vision therapy?
See, initially, I don't think so. See, suppression and diplopia is opposite, totally different. So, if there will be suppression, then there won't be any type of diplopia in that same patient. But yeah, later on, whenever you will start the vision therapy, later on that patient can develop the diplopia. So that can be there later on. But initially, there won't be any type of diplopia initially if there will be suppression. But sometimes it can be there, because always whenever he will try to focus, he will try to use his amblyopic eye, that can be there, but it is very infrequent. We can't say like it will be there.
So do you
I think Anish can Anish.
Yeah, do you think we can actually treat suppression first, then proceed with diplopia management, and then continue vision therapy? Is it a better idea to treat suppression first?
So it is, see, if we start the training, then we have to work simultaneously on this thing, because whenever we are going to see, again, to develop the fusion suppression means, if we are giving anti-suppression therapy to that same patient, that means we are going to work on the binocularity. We are going to develop his binocularity. So first of all, you have to work on all the monocular things. You have to work on, as I explained to, like you have to work on saccadic pursuit. That is also, you have to start monocular, then you have to go to the binocularity. So initially, if you start, obviously there won't be, there, that is not going to improve. If person visual acuity is 6/60, there won't be any type of anti-suppress, like you won't be able to perform that much. Yeah, we have to start it from the initial point, like you can start with the red and green glasses and then try to develop that physiological diplopia. But yeah, if we'll try to give directly anti-suppression therapy, I don't think so person is going to respond for that. Like in my practice, I have seen that. I don't know, there can be practitioners which can explain you better.
Yeah. Okay, one last question. Before treating amblyopia, do you think ERG should be normal? Is it necessary for ERG to be normal?
Yeah, it will be normal. Most of the case, it will be normal, most probably. But I don't know. There is a recently one study has done by, there is one of my colleague, we can see one of my friend he's from Singapore. He has done one study properly on the ERG, but he's saying like in the few cases there is some change in the ERG electrodiagnosis. But I don't know anything about that particularly on the thing, so I can't explain it better.
Yeah, so I think we need to look
till
at
now,
some
whatever study,
papers.
yeah.
Okay, thank you very much for the very insightful presentation. I think there are a lot of questions. We would answer them later because I think we are running.
Yeah, one more thing. One thing I just want to explain. There is some Satyam. He has explained about the syntonics. Just out of curiosity, I want to ask about the syntonics, as this seems to be very effective. As if so sorry to just answer this question. I just want to explain a little bit about that.
Yes, please. Yes,
Yeah,
go ahead,
in
go ahead,
India, in India, if you see, there are only two practitioners who are using currently syntonics optometry, and it is very like I have seen, like in the patients with the traumatic brain injury, or even patient is having any type of learning disorder, they are getting very good result. So if I talk amblyopia is nothing in front of the traumatic brain injury or all these skills. So definitely it is going to work very well. And I have read like around 10 to 15 articles on the from this on this syntonics optometry, and it works very well. So definitely it is, you should you should start with the some red green filter only, and it is going to work very well. So this is
Yeah.
the, I think, end of the session. We'll conclude the session over here.
Okay, thank you so much for your
Thank you
time,
so much, sir.
and it was a good discussion. And I think there are a lot of questions, as I mentioned earlier. We would take them later, and we would
Yeah.
send the answers or attach them with the pre-recorded video.
Yes, sure.
So thank you, Sumit, for coming up and
Thank
taking this topic forward. And I hope everybody has enjoyed and got some understanding about amblyopia and your thoughts on amblyopia management for today.
Thank you so much, sir.
Okay, so
Okay.
just a bit of housekeeping announcements again for tomorrow. The first thing, let me share my screen and let me show you what we have in store for you tomorrow. So yeah, tomorrow we have a session. It would be a different time. So we have Professor Bruce Moore, who will be talking about the management of pediatric population, the refractive management of pediatric population. So the timings are mentioned in the slide. It's at 7:30 p.m. Indian time and 10 p.m. Malaysian time. So he is going to talk about how you will deal with prescribing refractive error, or how do you usually prescribe for pediatric population. So I hope you guys can tune in. And just a bit of disclaimer, please. We have noticed that there are people who have not really registered with us before our joining, which is not, we don't have a problem with that, but we would like to make it available to people who had registered with us. So please don't share these links across. Definitely you can share the pre-recorded version, but those who have filled up our Google Forms, I would rather advise those people to be present for the session. So please don't share the links. That's a personal request. So be safe, stay home, and we'll see you again tomorrow. Bye.